Good evening. This is Dr. John Bennett, broadcasting from Miami for Neurosurgical TV in collaboration with Deepak Gupta of the Department of Neurosurgery of the AIMS Hospital in New Delhi. Tonight we have the pleasure of having, Chandrashekhar Deopujari, MD, a very experienced neurosurgeon. He's been all over the world training. I'd like to hear about that too. And we have some distinguished panelists. Let's go around and introduce the panel first. Okay, we'll start with you, Deepak.
Hello, good morning, Dr. Deopujari. Thank you very much for joining us at this platform. And Dr. Deopujari is a very accomplished neurosurgeon with a special interest in pediatric neurosurgery in India. He is the past president of International Society of Pediatric Neurosurgery and also the past president of Indian Society of Pediatric Neurosurgery. We welcome you, Dr. Deopujari, sir, and we look forward to your talk. Thank you very much for joining us.
Thanks, Deepak. Look forward to sharing some space with you.
Natarajan, could you introduce yourself, please? You're muted. You're muted. Natarajan, okay.
Am I seen? Should I?
Yes, could you introduce yourself, please?
Right. So, thanks, gentlemen. Very nice to see all of you on a Sunday morning. My task today has been to talk on the arachnoid cyst management, and we collected some data recently, and we'll review some literature as well and talk about specifically the endoscopic management of these cysts. I am speaking from Bombay Hospital in Mumbai, and though I'm interested in pediatric neurosurgery, we have experience with pediatric as well as adults as per the pattern of my practice.
Very good. Do you want to continue with your presentation, Dr. Chen?
So I'll go on the screen share.
Yes. Let's see if we can do it.
Are we on?
Yes, we are. We're on the. It's a bunch of slides. Yeah, there we go. Perfect. Very good.
Right. So basically, I think Manas has covered the ETV very well, and some of those points will come into discussion when we discuss the efficacy of endoscopic fenestration in arachnoid cysts as well. So let's go. I think arachnoid cysts are very well known that they develop because of either loculation or non-development of communication with the whole subarachnoid space, and the most common site are of course Sylvian fissure, followed by chiasmatic and suprasellar cisterns, interhemispheric fissure, cisterna magna, quadrigeminal prepontine cisterns, occasionally over cerebral convexity. And we are seeing more and more of intraventricular cysts. The earlier textbooks mentioned it to be a very rare abnormality. There have been some attempts of making anatomical classification, and the best known classification, which is dependent on communication with the subarachnoid space and size, is by Galassi, and this has been specially based on CT cysternography. I am not aware of a study done on MR-CSF flow study, but basically we talk about communicating, non-communicating, and then according to the size we talk about stage 1, 2, 3. Many of them are usually symptomatic, and when they asymptomatic, and when they become symptomatic, many children, especially in very young age, they can present with symptoms of hydrocephalus, like progressive head enlargement and occasionally headache in older children. Seizures could also be an important presentation, and focal neurological problems can be a presentation in some patients who are decompensated. So this is a typical example of an arachnoid cyst child who was diagnosed to have Sylvian arachnoid cyst at birth. Because of the slightly increased head, this MRI was done, and everything looks nice and lax, and there are no displacements, and it was decided to treat this child conservatively. But as the child grew, there was Around 6 months of age, the child decompensated, the head circumference started increasing and became symptomatic with seizures and some amount of right hemiparesis at the age of 6 years. And at this stage, the child was treated. Now, what options we have for treatment? We could either consider craniotomy with removal of membranes and fenestration into ambience and suprasellar cisterns, or we could use almost the same thing except for the removal of membrane, but manage to do a fenestration with either endoscope or microscope, or we could simply resort to cystoperitoneal shunt. There are some people who would do both the things simultaneously, or most people would do one treatment followed if necessary by the other treatment. And we have now several series which have talked about this, and what we see is that people have shown a very good result with cystoperitoneal shunt, more than 90% success rate in various series. Craniotomy and cyst excision also has a close to 90% success rate, but the percentage of patients requiring shunt seems to be a little higher, while endoscopic fenestration gives you about 70% success rate in this particular uh, series, or in fact, this is a collection of a few series meta-analysis, and about 30% patients have required shunt in this meta-analysis of 304 patients. There are obvious advantages to doing a microsurgical cyst excision, like that the whole cyst can be visualized, multiple fenestrations can be done, marsupialization is more effective, and if you want to do ECG monitoring, you could do it during that, and of course avoid long-term short-related complications. However, this is of course more time-consuming and more invasive technique, especially in very young children, and the brain handling uh, can create certain issues in terms of neurological deficits. Endoscopic fenestrations, which are becoming more and more popular, are of course minimally invasive, safe, and have been shown to be fairly effective. Um, Comparatively less blood loss, which can be an important factor in very small children. It of course avoids the shunt-related complications, and multiloculated cysts can be more effectively treated because with different trajectories you could make openings in various directions and communicate all of them together, uh, even with endoscopy, which can be a difficult problem if you are putting in a shunt. On the other hand, it certainly requires a more trained personnel and equipment, and reformation of membrane has been considered an important consideration. This is specific to some locations, as we'll come to it later on, and not it's very poorly understood why it should be so. So I think if we look at ventricular shunting, it certainly decreases raised ICP, and the problem then comes is, should we also be considering ventricular shunting? And this problem is much more acute in patients who have ventricular or paraventricular cysts. And I think this is another thing which we'll address as we go along. And of course, we have to worry about problems of delayed shunt infections, dependency occasionally, and need for revisions. So this is another patient. This patient has presented actually as an adult to us with continuous headaches. He is a high uh, demanding profession and high functioning individual, and he is bothered with headaches for the last 6 months or so, which have been increasing, and this is the scan he comes to us with. So how do we proceed further? So at the first instance, we have tried to we look him for other other parameters of raised intracranial pressure, and there is no papilledema, and there are no focal neurological deficits. So this patient has been advised to be observed closely for next 3 months, and then maybe repeat an MRI. And he comes back with a repeat MRI, which also shows that the shunt is undisturbed, but his headaches have not subsided at all. At this stage, we decided to do a mini craniotomy and endoscopic fenestration, and I would just show you how we do this. we do a small craniotomy slightly in forward, slightly in front of the cyst, because it is easier to close the opening, and then I am entering the cyst and trying to make fenestrations. We do not use an energy source so that especially the nerves are not injured. And in this kind of a, I'm using the monopolar diathermy probe only to sort of mechanically open it. And then to increase the fenestration, I am not using a Fogarty catheter because I do not want pressure to be exerted on the third nerve, which is fairly close. So the first fenestration has been made into the between the carotid artery and the third nerve, and we are entering now the interpeduncular cistern. You can see the nerves down there, uh, and this is the opening. Once we are coming out of it, I have got the widening of the opening is achieved by scissors, as I told you, and also by inserting the scope itself, which causes further dilatation. Then I am making another one between the tentorium and the third nerve, and usually we end up making at least three fenestrations like this. One will be between the optic nerve and the carotid artery. And then very occasionally the Liljequist membrane might also have to be perforated. Let us see how we go here. So we do not see any further arachnoid membrane beyond that, and the third opening is now being done between the optic nerve and the carotid. And this one I am dilating the stoma. There is some space here to do that. And again, make sure that you do not have a second arachnoid membrane. Is it necessary to do all three fenestrations? I am not sure, but to get a very wide fenestration is difficult. You can probably cut it in a linear manner, but it is supposed to, that kind of a stoma is supposed to close. So this is the post-operative MRI. The patient was actually relieved of his headaches almost the day after the surgery and progressively improved. And we do usually an MRI follow-up after about 3 months. I will talk about other location cysts where we have some other policy, but in this we have done this MRI at 3 months. You can see the turbulent flow suggesting that and we usually check it up also with a MR cineflow cysternography, where you can see a communication between the uh, cyst and the basal cisterns. This is the sagittal view of the same, and this patient has not had any further problem in about 9 years follow-up now. Another patient who's presented essentially with epilepsy, and here we again decided to do this case by doing a proper craniotomy because we wanted ECG recordings during the procedure, and the microscopic marsupialization has been done. Surprisingly, we could not record any ECG spikes either before or after, and we decided not to resect any part of the brain. And this patient has again remained seizure free almost now for about 8 years. What do we do if the patient is asymptomatic? I think observation, 6 monthly follow-up is usually done by most of us. The main argument against observation is that shorter the period of compression, more likely it is to recover. And this is argued by many people who feel that we should even treat asymptomatic patients if there has a mass effect. What some of the problems which we see if the arachnoid cyst is not treated, one of them is this. This is a teenage girl who was appearing for her exams, and in the middle of the exam she presented with sudden headaches. It is quite obvious that she has developed a subdural, and you will see that she also has sorry, I'm going back to this slide, and there was a hemorrhage into an arachnoid cyst, and this hemorrhage created quite a bit of disturbance, and she needed to have a drainage procedure. And at the same time, we were wondering what to do with the arachnoid cyst. Of course, with the presence of blood, making any fenestration does not make much of a sense. And 1 year later, you find that the cyst has reduced in size, and there is no subdural collection. So we are still observing this girl now about 4 years after the surgery and have not actually touched her arachnoid cyst. Another patient who has presented with a frank hemorrhage. First time around, this patient presented with hemorrhage as the first presentation, and she again required an emergency evacuation. And again, we have not fenestrated the cyst because of the presence of blood. And you will find that 1 year later, the cyst has remained the same. She's completely asymptomatic, no seizures at all, and the uh, subdural collection, of course, has resolved completely. She has had further follow-up scans, and the cyst has not progressed further, and she has remained asymptomatic. So again, the question is, should we electively uh, treat these arachnoid cysts after an episode of subdural hemorrhage? I think is still a controversial phenomenon. What do we do with the antenatal detection of a temporal arachnoid cyst? This is one of the antenatal consultations which we had for an arachnoid cyst in the temporal fossa. This is at the 6 months of gestation, and as there was no associated hydrocephalus and no other anomalies, we decided just to observe the child and keep a close follow-up. And this is the size of the cyst, as you can see. And this is about 6 days after birth when we did MRI of the infant. An MRI shows a fairly large cyst. However, there is no hydrocephalus, and this child is completely asymptomatic for raised ICP. The fontanelle is fairly soft, and we decided to wait and kept him on actually a monthly follow-up. And at 6 months, uh, the child started showing bulging in the fontanelle, became cranky, and I think this is the time. 6 weeks, in fact, sorry. At 6 weeks, we had the child with bulging fontanelle, and we decided to go ahead and do a fenestration. So this was fenestrated endoscopically, and the child responded initially, but the head circumference kept on increasing, and we subsequently shunted the child at 6 months of age. Suprasellar arachnoid cysts present a different kind of a problem. Many of them present in teenage children, either with gelastic epilepsy or occasionally with raised intracranial pressure. And in younger age, they present with raised intracranial pressure. Older age, they present mainly with gelastic epilepsy. And you will find that this third ventricular cyst is usually the sella remains normal, and uh, there is a functional aqueduct stenosis. So the best way to treat this cyst would be, uh, before that I will just give a explanation of why I was talking about the sella being normal. There are another kind of cysts in this region which are actually predominantly sellar cysts, which can also develop into third ventricle, and these patients usually present with visual disturbance, hypopituitarism, and there is usually no hydrocephalus. So you need to differentiate between these two. And the best way to treat this is to do a frontal burr hole, and this is an endoscopic fenestration. I am using energy source. I am using unipolar diathermy to coagulate the cyst membrane, and then to enlarge this cyst as much as possible. Insert the uh, endoscope inside to make sure that I do a double fenestration, and we would do a fenestration here into the interpedunculair cistern like a third ventriculostomy. And the results of uh, two fenestrations or bilateral fenestrations, biportal is not the correct word, bilateral fenestrations on either side of the cyst to communicate into the cisternal component has over 92% success rate, while if you do only a only one wall fenestrations, the success rate is around 60%. And the main reason for this is the functional aqueductal stenosis after the cyst collapses might open up in some cases, but it may not open up in some cases. And actually, there are some suggestions in literature that after you do the first fenestration, you can probably inject a dye, make sure aqueduct is patent or not, or see it by endoscopy itself, and then decide if you are going to do the second fenestration or not. But I routinely do fenestration in both the walls in all the patients rather than depending on aqueduct patency. So this is the child. What you typically see is that the cyst just decompresses. It does not disappear, of course, but you can see the CSF flow sequences, the turbulence of CSF at the bottom of the third ventricle, the flow going through the stoma in the prepontine cistern. On the other hand, the cysts which are enlarging the pituitary fossa, presenting with visual symptoms, they are usually seen in older age group, and these patients are best treated by this is a endoscopic method, but a transnasal method. You can see the thinned out cellar floor, and this is the cyst which we have first punctured, and you typically see some kind of a ball wall mechanism, if you can see it over here, which has definitely caused this and that is being closed with fat. We used a glue to do this, and then you close the sella in a proper manner so that you do not get leak, and this seems to have
Excuse me,
solved the
Doctor.
problem.
Okay.
Yes.
Okay, I can see it now. That's fine.
Okay.
It's fine.
So I was just trying to show the ball wall mechanism in the stoma. You know there is a small opening over here, and you could actually see it with every pulsation that the CSF is egress into the cyst. So we close this and then we plug the defect, and this is how this patient has been treated. These are post-operative CT scans. There has been definite improvement in the visual function. However, the hormonal function hardly ever shows improvement. These are not as common as the earlier shown suprasellar cysts, which are more commonly seen in children. What do we do about intraventricular arachnoid cysts? And I think here endoscopy has really made life much easier, because to get into intraventricular cysts by an open surgery probably is too much of a maneuver and cannot be very effective, as you cannot enter all parts of the ventricle by one portal entry. The only problem with endoscopic cyst fenestration is that there is a toughness and vascularity of the arachnoid membrane, which can make it very difficult sometimes to enter the cyst membrane, or if there is a hemorrhage, then it can create a problem for you, and you should be prepared for that. So this is one typical patient. This patient presented at the age of about 6 months with enlarging ventricles, bulging fontanelle, and again double fenestration is important. So we have entered into this cyst, and once you enter into this cyst, make sure that you do not cause any hemorrhage. There are usually some vascular areas. You can test that area quite well with one of the instruments. Go inside the cyst, and then usually we will make a second fenestration also, so that the cyst has been opened at least in two different areas, and CSF flow is established in a much better way. And this is actually within 3 weeks that the cyst has collapsed substantially, with a mild subdural which cleared up later on. Another cyst, this is a patient who had a difficult birth history and presented to us with mild infection, and this patient was treated with antibiotic, and this was a small cyst which was seen at that time. This child comes back to us about 6 months later with enlarging head, and now you can see that the cyst has enlarged with some amount of hydrocephalus. This was again tackled with endoscopic fenestration from a frontal burr hole, and you can see that the cyst has resolved substantially, with also reduction in hydrocephalus, because that was causing the functional aqueductal opening. Larger quadrigeminal cistern arachnoid cysts can also be similarly treated. We usually do a third ventriculostomy as well as an opening into the quadrigeminal cistern cyst, and this is one such patient where there has been a reduction in this. However, this is one patient, I must say, who had probably the membrane reformed, the cyst reformed, and this patient required a second surgery before this problem was resolved. When you have cysts in other areas, you have to use innovative approaches. This is a patient with an interhemispheric cyst, and I think what we have done here is that we have entered into this cyst from the opposite ventricle in this manner. I think probably we will have a picture here. So this is the cyst, as you can see, in the coronal plane, and this is how we made a septostomy, and septostomy alone resolved the problem for a while. However, though there was no loculation, the ventricles remained large, and eventually this patient required a ventriculoperitoneal shunt. This is an adult patient who presented with raised intracranial pressure and dementia over a period of time. This is the kind of cyst this patient has presented with. So the dilemma was really how are we going to approach this cyst, and I found that as the ventricles were not enlarged and we did not have a definite trajectory to enter the ventricle without disturbing substantial amount of brain tissue, we decided to do a small opening. So we did a small parasagittal craniotomy, entered the cyst, and fenestrated it into actually the interhemispheric cyst at the bottom between the two olfactory tracts. And at the end of 3 months, the patient comes back with a scan, substantial improvement in walking and dementia. The presentation was more like a normal pressure hydrocephalus in a 40-year-old person, and this has completely resolved with complete relief of the symptoms. So microscopic fenestration still has a substantial role to play, especially in cysts in such odd areas. This is another patient. We have been thinking how are we going to approach this, and I cannot find a cistern except for the surface cistern itself where I can open this. So I decided actually to do a marsupialization of this cyst, and a microscopic marsupialization. This is immediately post-operatively. We kept this catheter for a short while to see if something was draining, and removed it after about I think 4 or 5 days. Posterior fossa cysts, I think, are still a problem. This is a child who has presented to us with the deformity of the fourth ventricle, as you can see, a cyst which is in the CT angle with some amount of hydrocephalus. And this cyst, we found it very difficult to find a place to fenestrate it substantially. And I think even today, one of the best ways probably to tackle such cysts is to make a small craniotomy and marsupialize this cyst, like this child was done, and the hydrocephalus has resolved after marsupialization of cyst at 3 months, and the cyst has substantially reduced with normalization of the anatomy of the fourth ventricle. So I think if you look at the literature, we have definite evidence that decompression of arachnoid cysts yields a substantial clinical benefit with a low risk of severe complications, which may partly answer that should we be treating asymptomatic cysts or not. But I think this decision in an adult is probably easier because the symptoms are more manifest and they would complain about it. In very small children, you may have to consider, if you find a very large cyst, that you may treat an asymptomatic patient. The other things which we look at by some authors who have concluded that surgical treatment of arachnoid cyst is overall good outcome, but most people practice microsurgical decompression, and this is true with most of the papers which came in 90s and early this century as well. And people still maintain that microsurgical fenestration, especially for arachnoid cyst, has provided superior results than just endoscopic fenestration. Macom's review in 96 have shown two important factors: that the success rate of fenestration among these patients with associated hydrocephalus was higher than those without hydrocephalus, was significantly higher than those with hydrocephalus. And the other thing which I showed is that in those patients with hydrocephalus, cyst fenestration with or without a ventriculoperitoneal shunt has been practiced, and they found that cyst penetration with ventriculoperitoneal shunt help these children in a much better manner. This is another paper from Europe which has shown that the patients with symptoms related to intracranial hypertension, acute neurological deficit, and macrocrania has obviously the best operative outcome, and patients with the same side epilepsy syndrome also have a good outcome. Marsupialization represented the best surgical option in this series. Actually, this was a survey conducted by DeRocco and colleagues, and they found that there is the responses which they got from all over the world. That analysis showed that cyst marsupialization presented the best surgical option. Uh, Endoscopic cyst marsupialization is now considered, though it is practiced exclusively by about 28%. Many people feel that with a mini craniotomy, this may still be the best outcome. I would conclude by saying that though endoscopic fenestration, microscopic marsupialization, and ventriculoperitoneal shunt all have well-defined options in arachnoid cysts at many other locations, I think surgical options are not so clear in temporal arachnoid cysts. We can only say that surgery has a definite proved benefit, that endoscopic fenestration is the current flavor, and cystoperitoneal plus minus ventriculoperitoneal shunt is probably the first option when the patient has an associated hydrocephalus. Thank you for a patient history.
Thank you, Dr. Chan, for quality presentation. Okay, we'll open the panel up for questions. Okay, Deepak, do you have some comments or questions?
Thank you very much, Dr. Deopujari. Excellent presentations. I don't have any questions. It's quite explicit.
Okay, thank you. How about you, Natararan? Do you have any questions or comments for Dr.
Deopujari, there was an excellent presentation, and I just have only one question. When you started your presentation, there was the first case which you showed with the temporal arachnoids. You said you had done a mini craniotomy to do the fenestration. Can you tell me, elaborate why there is a need for a mini craniotomy rather than a simple burr hole in the
Absolutely. So, if you have a large temporal arachnoid cyst, earlier and even today in many cases, we try to do a mini craniotomy. I do this kind of a thing even for, when I treat below 1 year ETVs, I try to do a mini craniotomy because I can get a good dural closure. Apart from, the subdural effusions, one of the problems which we have faced is also actually CSF leakage from the wound. And I think that has been a major advantage by doing a mini craniotomy. Your dural closure is better. You can take a small flap and then go in. Later on, we have changed to making a burr hole adjacent so that you have some amount of brain matter before you enter the cyst. So these are the two options.
I thought the way you, this is really interesting because dural closure is, watertight dural closure in a small burr hole is really difficult. And my initial impression was that maybe by doing a mini craniotomy, you are able to get a better angulation of the scope so as to reach the different portions. Is it so, or that really does not matter?
No, at the base it really does not matter. I mean, yes, it might avoid two burr holes if you are doing a posterior third ventricular lesion. It might avoid you two burr holes because you get better angulation. But in temporal arachnoid cysts, that is not the reason. The main reason is the CSF leakage and better closure of the stoma.
Okay, very good. Okay, Dr. Chan, we'll wrap it up. And you can get off the screen share. Just click on the green arrow to get off it. And I'd just like to say, Dr. Chan, if you want to teach in your senior years, this is a great platform to do it. You can teach all of India from your home.
Thanks, John. I think this is my first experience, and it's really wonderful to see some friends and share some experience on a Sunday morning. Thank you.
You'll be able to continue to share your training and all your experience from your home, and I look forward to hopefully hearing you in the coming years. And thank you all.
the rest of the day.
Okay,
I just
thank you.
want to add, Dr. Deopujari,
Yes.
it is just
Yes.
not for people who are watching you. This is being live telecast, and there will be lots and lots of people who will be watching you both online and subsequently offline on Neurosurgery TV. So whatever talk you have given will be seen by lots and lots of delegates, and you can subsequently see your talk, how many people have viewed your talk after 1 month, 1 year down the line. So this is a very, very important and a strong teaching tool, and I really thank you very much on behalf of this online conference group that you agreed and you spared your valuable time for this. Thank you very much, sir. Thank you.
No, no. Thanks, Deepak, for this initiative, and thanks, John, for all the hard work. Thanks.
Okay, we'll be seeing you soon. And thank you, everyone. We're going to start with Dr. Cherian's in about 15 minutes. I'll send everyone a new link to come in. Thank you. We'll see you then.
Yeah.
Thanks.
In the meanwhile, we